This conference will now be recorded.
It's not doing it? Are you repeat that? Okay, thank you. And then Hi, I'm Dr. Peter Winn. It's great to be here today, and we're going to go through several areas. You do have the handout, I believe, and I do have the PowerPoint slides. I'm afraid I'm going to be in the middle of the screen. So I guess if there's less people here as we go along, maybe you can move around and be somewhere else, especially you. Hi. So I've been coming here for about 6 or 7 years. As you may be aware of, the course is given twice a year. So initially, I was when I was first giving this, I got it as session number 17, I think. And then you had your exam on 18. I said, no, I want to speak earlier in the program for you folks. I am a medical director of a long-term care facility. I'm also a medical director of a hospice here in Oklahoma City area. I'm a faculty at the Department of Family Medicine at OU. I'm board certified in family medicine, geriatrics, and hospice and palliative medicine. I've been at OU. I'm one of those old dogs. I've been there 30 years as of October coming up. And so I'm kind of like a geriatrician. So my main role here, even though we're going to go through several areas that are on the screen there, is I want you to get an idea of perhaps what your expectations should be of a medical director when you're going to be administrators, hospice, home health, but specifically post-acute long-term care. And long-term care does involve hospice, does involve home health, does involve hospital patients, clinics, patients, and assisted living. Most of what I'm going to be talking about is related to subacute or skilled nursing care and long-term care nursing home rather than assisted living. But I will say that the assisted living patients I take care of now are what population was in nursing homes 20, 25 years ago. So these are complicated patients in assisted living as well. So where you're going to be as administrators, you may be administrator in assisted living, and you may be administrator in long-term care, or those may be completely separate buildings or on the same campus as well. And some of you, as you go through your careers, you find yourselves going higher in administrative work, rather than just have a facility. You may be, a long-term care. Enterprise, I guess, is maybe it. So you may be involved in an enterprise that goes across several states rather than just Oklahoma. And the thing to remember, of course, is depending on where you go, a lot of the regulation may be the same, but the legal aspects of healthcare may be different. What I'm referring to is advanced directives for healthcare, DNR policies and procedures and things like that. We don't have assisted suicide here in Oklahoma, but if you're in Oregon, they do have assisted suicide. So again, it's going to depend as you go through your years. What I'd like to do is just very briefly, if you could just tell me what discipline you are, whether you're a nurse, an LPN, whether you're in a a nursing home already or long-term care, kind of just very briefly in like 30 seconds, because there's a lot of material I want to kind of go through. But why don't we start with you, Terry?
My name's Terry. I'm a nurse at a long-term care.
Okay, good. And Tracy?
Tracy, I'm an RN in long-term care, but I do consulting.
Okay.
My name's Felicia, and I have a home health agency.
Home health, did you say?
Yes,
Oh, okay. And Cindy?
My name is Cindy, and I'm the COO of an ICF.
Oh, okay, there you go. Okay. And Jessica?
I'm a social worker by trade, but I actually do admissions for a hospice corporation here in Oklahoma.
Okay, there's that word, corporation. That's probably what I was looking for. Blake?
I work in a nursing home and I do skilled billing and business office.
Okay. And Nola?
Surgical technologist at an outpatient hospital.
Okay. And you are?
Edward,
Edward?
brain injury facility.
Okay. Philip?
Philip, and I'm IT for long-term care corporate.
Oh, wow. So I gather you're here because you, at some point you want to become administrators, either at the facility or maybe higher level above the facility. Yeah. Okay. That's great. Sometimes we've had some speech pathologists, sometimes some physical therapists and speech therapists that have come in going into this career. Let's see, the change. Yep. So usually I move around because I don't like to be standing in front of the screen, but we'll see as best we can do. So I have no relevant financial relationships with the manufacturer of any commercial products or provider of commercial services in this presentation, although I do work at the national level, and I'll tell you a little bit about that as we go through. So some of the objectives I have here, I kind of put this together. I've received some guidance from Z and administrative universities, the material that I covered, but I've actually kind of probably gone beyond that, and I wanted to have really a more medical director focus. So I'm going to talk about the 4 key roles of medical directors, separate from what's in the state operations manual as far as the FTAG 841, which relates to medical director. Did anyone discuss FTAG 841 to you yet? No. Okay. We're going to talk a little bit about infection control and post-acute long-term care. And again, these are broad brushstrokes. I can't, in each one of these areas, this could be 3, 4, 5 hours. So I'm giving you an overview. We're looking at standards of practice. That's part of what's in your curriculum. I'm probably going to spend like 10 minutes on that. And then also I'm going to be talking about, and I added this in, the quality assessment performance improvement. So this here is the book I came across, actually at a national meeting several years ago. This is meant for administrators and women. I know you have a lot of material that Z may have introduced you to. So it's meeting the leadership challenge. That's what you folks are going to be doing, leadership as administrators in your facilities. And you can, I think that you can Google this and buy it online. I think it may be 30, 40 bucks. And there's actually another one kind of that came out in 2018 by the same authors. And this one's called Long-Term Care Leaders Guide to High Performance. And it does get into a lot of more relevant, updated material, especially as it relates to quality assurance, high performance leadership. And so if anything, you probably want to get this one, but they're both out there, same authors. Okay, this one's Long-Term Care Leaders Guide to High Performance, and it's exactly the same authors as this one that's showing, but the one author is more prevalent leading it. So that's the 3, but the different kind of listed. So, okay, good. It's kind of awkward because I don't have the screen in front of me, it's over there. And it's behind me. So this is a American Geriatric Society does have journals, but it's kind of familiar. You can advise yourself with this. Annals of Long-Term Care, the Clinical Care and Aging. And that's a lot of good articles in that. And again, you have these, so I'm going to kind of go through these. This is the Journal of the American Medical Directors Association, and it's called the Journal of Post-Acute Long-Term Care Medicine. This is for physicians, nurse practitioners, PAs. But there's a lot of articles from different countries around the world where we realize that we can learn about long-term care or what the best practices in other countries. It does go through that. And I do work with the Society for Post-Acute and Long-Term Care Medicine at the national level out of Baltimore. And this here is some of the journals that you may be wanting to look at. Oh, let me go back. Yep. There's McKnight's. Okay. I get that. They send a lot of, you can probably go to their site, McKnight's, and they send out emails, articles. They actually have a written pamphlet, which can be helpful. And then there's this journal here. These are ones that you should be getting as an administrator or in your facility. It's the American Healthcare Association. That's the for-profit nursing home organization. Puts that out. Provider. There's some good articles in there. Medical direction in the nursing home. This book is actually 20 years old, but was really at the forefront of organizing and training physicians to be medical director administrators in long-term care. It's very helpful by a Dr. Petit. I actually do teach a course at the national level on medical direction in long-term care. And every time I do this course, I go back to this book and it's still relevant. So for your medical directors, that might be something you could suggest that they look at. This here is maybe the only conflict of interest I have, but again, this is for providers. It's a pocket guide, post-acute long-term care medicine, related basically to skilled care and long-term care for, as I said, physicians and PAs and nurse practitioners. You can see this is a labor of love that Dr. Fenstermacher and I have done. Second edition, and actually we're about maybe to do a third edition depending on who's available. A lot of physicians and other people in healthcare are very, very busy with the COVID pandemic we have, and I'm not sure that we're going to be able to do a third edition, at least, but anyways, we kind of started on that. So this is where I've been. You may be familiar with AMDA, American Medical Directors Association, but it's now renamed the Society for Post-Acute Long-Term Care Medicine. You can actually Google that. You can cpltc.org. And the vision statement looks at patients and residents to ensure they receive the highest quality, compassionate care for optimum health, function, quality of life. I've been involved with this organization probably about 20, 25 years, sat on several boards. So I'm going to give you some of the role of the medical director as it relates to what we believe as a society should involve. And again, we talk about, for instance, we talk about MDS, minimum data set. Familiar with that? Well, that's minimum, okay, data set. You can do a lot more gathering of information and data other than what's quote unquote in the minimum data set. But I will just say that the minimum data set is a good geriatric document. Believe it or not, that's what geriatrics is all about. It's not necessarily what their memory score is or what their blood sugar is or what their blood pressure is. It goes into just good evaluation of cognition and function, really. So here we're going to talk a little bit about the role of the medical director, what you need to know, but are afraid to ask. So your medical director is a physician administrator. We do have various roles and responsibilities. And actually, I'll allude to, as we get towards the end of this part of the PowerPoint, about 9 areas that medical directors may be involved with in your facility. And again, if you go to the website I alluded to, it will probably give you information on the expectation and obligation of functions and behaviors, a task that the medical director should have. So according to the National Association, and again, the National Association is really the only association out there that looks at medical directors for long-term care and other providers. They do have a lot of guidelines that are multidisciplinary, PT, OT, nutritionists, speech language pathologists, physicians, nurse practitioners also involved in various guidelines that they may have. But that organization does define 4 key roles. Again, these may overlap with what's in the state operations manual as far as regulation. So physician leadership. I'm sorry, I have to just jump. You're looking behind me. It's awkward. So physician leadership. Okay, so remember that as the medical director, yes, we may be taking care of patients as well, but the role of physician taking care of patients and a medical director who's taking care and oversight in the sense of all patients in the facility, there is a difference there. It looks at overall care and clinical practice in the facility. That's important. So, and again, relationships are very important. We're all challenged with staff turnover. Where I've been medical director, I guess I've been there, probably medical director about 20 years. Our group's been going out to that facility ever since it was built 35 years ago. So, but it is important, the staff turnover. Have a new DON in the last 2 months. I do have a new ADON in the last month, and I have a new administrator in the last 3 or 4 months. I did have an administrator that was there several years. We got one administrator that lasted 4 months. Now we're on our third administrator in basically 9 months, although the first one was there for an extended period of time. And actually, she took this course several years ago. So we do, and again, this is within the regulation as well. According to the State Operations Manual, we do have obligations to oversee care provided in the facility. That can include physicians, nurse practitioners, PAs, and also rehab, speech pathologists, rehab. We do have responsibility to oversee the care that is being provided. Now, you may say, and a lot of physicians may say, I can't do that, or medical director, I'm not involved with that. But as you go, in the sense of maybe be a medical director of medical directors, a corporate medical director, they will be involved in various areas. Survey is an important aspect. We always encourage the surveyors to be in contact with the physicians. Here in Oklahoma, I think some of them are apprehensive about speaking to physicians, let alone medical directors of facility. Where I'm medical director, I always say the survey comes in, whether it's a complaint survey or an annual survey, I want to know that they're in the building. If I can, I'm going to come by, I'm going to introduce myself and be available to them either in person or by phone. Also, it's important, I believe, for, if possible, that the medical director of the facility where you are be available and present when the surveyors do the exit interview. And it's very important that they be involved. I'm always surprised when I do introduce myself, and this kind of shows, he said, Dr. Winn, you're the only medical director or one of two medical directors that come and speak to us while we're in the building, or introduce yourself, make yourselves available, or at your exit survey. So things are going well. I mean, I have had an exit survey that lasted 10 minutes about 2 or 3 years ago. I thought that was pretty good. That means there wasn't a lot of things going on, but there can be important information. I've actually had the surveyors come and ask me about particular patients that were mine or not mine, and I would review the chart and get back to them. So that can be helpful.
Is that a reason medical doctors don't want to be discouraged or don't want to be part of the survey? Is that a reason?
So the question is, there's a perception that medical doctors don't want to be part of the survey. Let me answer that in one way. First of all, there's a lot of physicians now that are very, very busy. And so there's not that many physicians that actually like to do long-term care. Just put this on. Sorry, I meant to put this, okay, there we go. Let's put this on vibrate. So if I start shaking up front, you know it's my pager, not me. It's audible now. I think I took it. So Usually it would be the medical director that we would encourage / physician to be available. They may not be available because they're in the hospital, they got a busy clinic, they may be at another nursing home. That's why it's important to kind of keep in contact with the administrator or the director of nursing, because they'll know when they're going to be doing an exit interview. They'll be the surveyors will say, well, we're going to be doing it at the end of the afternoon, or we'll be back tomorrow and we'll do it. So that can kind of give you a heads up. But I think it's important. I think you should have an expectation as administrator that your medical director should be there, if possible, at the exit survey. I've actually had deficiencies. Now, they're not going to tell you what deficiencies you're going to get, but we have been aware of deficiencies that could occur, but because as medical director I was there, they were not cited for that. Now, surveyors are much more strict now, so that's something we certainly need to deal with. So patient care and clinical leadership. So we have clinical skills. Again, I'm a physician, I'm a geriatrician, I do hospice-based medicine. I think I'm fairly good at communicating with patients and doing presentations. So again, we are administrators. So we need to remember, when we talk about medical directors, it is separate from being attending physician, although the medical director may also be attending physician for patients. But very rarely will you have a medical director who's just a medical director, not seeing any patients in your facilities. It is important to keep the other providers, nurse practitioners, PAs, physicians involved. And what I like to do at my facility is I said, okay, I'm going to be your medical director. I want to have a provider meeting with our, the people who are providing the care every 6 months, which is a dinner meeting. It's really nice. It's in the independent living dining room. And we go over what our concerns are, what the attendings may have as concerns. Usually do it after the survey process is done. We've done the survey, we've done our plan of correction, and then, okay, these are our deficiencies, and kind of go over things. So that could be helpful. It says patient care and clinical leadership behind me. That's okay. So a big thing when surveyors come is basically, this is what surveyors are really wanting. They want to be respectful of patients that we take care of, the residents' preferences for care, their choices. We want to make sure resident rights are respected and dignified care is given. And I think, I'm not sure if you've gone over it yet, but they will give you a handout that's one page, but it's double-sided and goes over all the F tags. And if you look at that, you're going to see resident rights is like 20 to 25% of the areas of the F tags, areas that they're going to be looking at. But person-directed care is very, very important. And that's what the surveyors are going to be looking at. Everything else comes underneath that. So quality of care, again, helps the facility develop and manage quality and safety initiatives, including risk management. So there may be corporate risk management, and that's kind of at the higher level, but also gets into like ethics of administration in your facilities. And depending where you are in that chain or that ladder, you may be involved in corporate risk management. Okay, you want to have good outcomes, and you want to decrease the risk of bad outcomes in your facility. And we'll talk a little bit about that later on. And you need to keep, if possible, engage your medical directors. It is part of their responsibility, and it will be to different degrees where you are. Probably Oklahoma, the medical directors are probably not that involved. Okay, they may be where you are. How many where you folks are, where you have a medical director, how many, raise a hand, that are actually maybe not involved as much as you would like to say? So I see 50% at least, and the other 50 is, okay. It's, healthcare is a big business. It's pretty complicated. Quality care is, and quality of services. So the QAA stands for Quality Assessment and Assurance Committee. That we'll be touching a little bit later on during the presentation on that. And we'll talk about QAPI. My understanding is CMS is not very happy when we call it QAPI. They say it's QAPI. So again, quality of care, there's various state levels and national standards, and we'll talk a little bit about that. And again, this is what the physician and medical director needs to be aware of. And then obviously the care that's being provided by other clinicians, staff members, and then patients as well. Looking at admissions and discharges and transfers, now we have CASPER reports that talk about the readmission rates, the ER rates, talk, how many times people go to the ER, do they get admitted, especially if they're on skilled or rehab. Why are they going back to the hospital? Could you kept them at the facility instead of sending them to the ER? Even more so now with the COVID-19 pandemic. Patient just yesterday, he went into urinary retention because of cancer. And talking to the director of nursing, who's been there 3 weeks. She's really good. She used to be a ER nurse, so she knows her medical stuff. I was really impressed. I spoke to her today because this is the first time meeting her. I was talking to her on the phone and trying to introduce who I was, what we do while we're there, how long we've been going to the facility, giving the history. And initially it was, well, we'll send him to the ER, but she was able to get him into his urologist office on the same day instead of going to the ER, possibly exposed to COVID. So it was, so these transfers, so we avoided a transfer to the ER. Didn't have to use it yet. So again, what I look at, and I'm going to diverge a little bit, is that when I get a call, say, Dr. Winn, your patient's having diarrhea. As an attending physician, I'll say, okay, well, what's going on? This is what we need to do. Maybe get some lab. I don't need a lab today, but tomorrow, but I'm going to get them on some medication now. I want to try to prevent them having to go to the hospital, prevent them from going to be admitted, whereas we can take care of a lot of these conditions in the home. So, but I'll also ask, okay, I'm medical director, what other questions might I want to ask? Well, are there any other residents on that wing or facility that are having diarrhea? Are there any staff that are called in sick because they had diarrhea? So looking at the big picture. I always remember one facility where I was medical director years ago, they said, the director of nursing said, oh, we're really good at healing pressure ulcers, but we're not good at preventing them. Okay, that's a system problem. Okay, we talk about systems in the nursing. In fact, so this is a paper from Annals of Long-Term Care. This is from February, and I actually came across this last night that I was going to talk about, but it's Association of Skilled Nursing Facility Quality Ratings, Quality Measures. Anyone talk to you about quality measures yet? A little bit. Pressure ulcers, falls, antipsychotics. Anyone familiar with the CASPER reports? Some of you are nodding yes. Your facility should know how to access their CASPER reports. If they can't, contact the survey agency. They'll be able to help you. They will give you the demographics of your population. They will look at these various quality measures. Where you are now, if you're in a long-term care facility, you can go to CMS. You can just put in nursing home compare, and you can put in the nursing home where your mother is, or where your brother works, or where you are, and it will show you various quality measures. So what CMS is saying, we want our consumers to have access to the information that they would want to know, at least what they think they would, family members would want to know, so that they can choose this SNF or that SNF, A or B, or this long-term care facility. And again, so it talks about does the quality measures affect the 30-day rehospitalization emergency room? That actually is a quality measure. Rehospitalizations within 30 days. And that's not good for the hospital, because if they get readmitted for the same diagnosis they were discharged from the hospital is going to get paid less. CMS will say, well, you let them leave the hospital before they were ready to go, and they're back in 3 days later because you didn't do a good job. Okay, so sometimes it's the hospital versus the rehab, but that's Also, where hospitals are actually interviewing for preferred providers of skilled care and rehab care. And it's not necessarily at the start, but they'll look at the star ratings, as well.
Our agency is on a preferred provider list
Yeah.
to the big hospitals here in Oklahoma City already.
Good.
Yeah, we had to go through a lengthy process to interview and apply for those.
Congratulations. Education, information, communication. I think it's important. And again, sometimes some medical directors may be more involved with this than others as far as maybe doing in-services, but certainly communicating with the ADON, the DON, the administrator. Sometimes it's hard to get them together. It probably should really be having a periodic, I guess, threesome or foursome meeting outside the COPI. So what education, again, what's going on as far as regulation, what are the politics, the economic factors, funding, the funding for healthcare is changing. It's kind of like, in a sense, believe it or not, it's kind of like managed care in many ways. But the way that healthcare is being provided and paid for is different. So basically, the federal government is saying, we want better outcomes at less cost. Okay, for the individuals that are in the healthcare system. And on top of that is patient satisfaction, which is really hard to measure. You need to know what your vision, mission, and values are of the facility where you're going to go into. So if you're interviewing for a job, you may say, okay, well, tell me about the vision for your facility. Show me your vision statement, your mission statement. What values do you have? So I provided the course at the national level, I actually take the mission and value statements for where I am. That can change. Where I am, it's being nonprofit to profit and different owners over time. I'm actually the person with the long biography. I'm the one that's been there the longest. I've been going to that facility for 30 years. No one else has. So I know a lot about the history. Okay. 841. Okay, this used to be FTAG 501. Now it's 841. All the FTAGs were rewritten. Several degrees, probably about 4 or 5 years ago, maybe a little bit longer. But anyways, the FTAG as far as medical director. These are quotes taken verbally from the State Operations Manual. Now, the American Healthcare Association that publishes the Provider Magazine, they do publish in print the State Operations Manual. You can go online and look at that material, but I'm not a good person reading documents online. I mean, I can go through 100 pages of the Operations Manual within probably 10, 15 minutes, whereas if I was scrolling, probably take me more than an hour to get to perhaps where I want to go. But anyways, it says the facility must designate a physician to serve as medical director. Actually, when I became interested in becoming a medical director back in the, I guess, early 80s, maybe early 90s, yeah, early 90s, there were actually the medical director of a skilled facility was actually a non-physician. That doesn't happen anymore. CMS has changed that. But the medical director is responsible for implementation of resident care policies and coordination of medical care in the facility. What it says. That may scare a lot of physicians away from becoming medical directors because in theory, they can put the medical director at increased liability. If something goes wrong in the facility and the attorneys feel it was because you weren't fulfilling your role as a medical director, that's why this bad outcome occurred, whether it was a fall or a stage 4 pressure ulcer or impaction that resulted in ischemia of the colon and someone had to have a colostomy put in. It's all there. However, there is a proviso, and basically what they're looking at is that the medical director provides oversight and guidance as to the implementation of resident care policies and as to the coordination of medical care in the facility. Now, medical care in the facility is care that's been given by the nurses, attending physicians, the rehab people. It's all inclusive. The podiatry that comes in, or the ophthalmologist that may come in, although it's hard to have some of these people coming in now with COVID because they're afraid they're going to get exposed to COVID. So remember that. So while many medical directors serve as attending physicians, the roles and function of medical director, which I alluded to, are separate than that of attending physician. We're looking at coordination of facility-wide medical care. So one case of diarrhea, are there more cases of diarrhea in the facility? One case of COVID-19, are there more cases? You're going to be involved in screening. There's new CMS guidelines, which are compulsory. It's not even guidelines, it's compulsory, that they have to screen all staff once a week for COVID-19. I want to talk to my director of nursing and say, are you aware of this? He says, yes, we are, and we've implemented that already. We did the night shift last week, we're doing a day shift this week, but yeah, it's going to be every week. So my other question was, okay, I came in with 3 or 4 other physicians this morning to see patients. What do you want to do with us that are coming into the facility? What is your policy and procedure with respect to the radiologist or the radiology technician that's coming into the facility? And so that's it's important to be looking at as far as the COVID testing. So I need to check that. So
Are they gonna make you test?
well, probably yes.
We're making ours.
Yeah.
Anyone, even vendor, any vendor.
Yeah, I mean, that's probably what, because she wasn't sure whether it was to be vendors as well. I said, well, look into it, let me know what your policy and procedure is going to be, let me know.
I was wondering what.
As far as our doctors, we could do it in our clinic. We could probably, even if the doctors are there, we could probably have them do it while they're there. Because we come out, usually, my group goes out Thursday mornings. I go out more often. I've been tested 2 weeks ago, it was negative, but I haven't tested since. But it's something that needs to be looked at. Being at OU where I am, they actually sent me an email yesterday saying, hey, what about you guys? I'm going into the nursing home. Have you heard about this new guidance for, and I said, yes, I'm aware of it. And when I'm there tomorrow, which is today, I'll be talking to the DO. So that's good to hear, right? Guidance and oversight, as I alluded to, that's the intent of FTAG 841. And also, quality of life is really the big thing. That's what the surveyors are looking at. Really, it comes down to, they're looking at ensuring that the residents in your facilities are having a good quality of life, receiving good quality care, and a safe environment, and that care is provided in a very dignified and confidential manner. So resident care policies, and again, you have this as your handout. Where are you with respect to your policy, admission policies and procedures? I have had surveyors ask the administrator, show us your policy and procedures as relates to a patient that's going to get admitted to your facility. What are you telling them? What their rates are and all that type of thing? You're going through their advanced directives. Integration of care delivery and services, again, transitions in care, certainly either between the hospital and the skilled unit / nursing home, or even maybe from your assisted living into your long-term care. So for example, I recently had a lady who is actually quite stable, but she's living in the assisted living. And as we know, assisted living in Oklahoma is private pay, although in some states, Medicaid may actually pay for assisted living. There probably are the occasional exception, which you won't be told about, that someone may stay in assisted living under Medicaid. Very rare, but they don't want to put people in a level of care that's not that a patient or a person doesn't need. Maybe more restrictive for them in the nursing home rather than staying in assisted living. So, but in certain states, so when you go to another state, you're going to be administrator there, Medicaid may actually pay for assisted living. So it's something to kind of be aware of. But anyways, this lady transferred because she spent down. She spent all her money. She had no more money left. And then but she needed long-term care assistance, and she transferred into the long-term care part of the facility and is applying to Medicaid. And so the most important thing from a physician point of view between these transitions of care is medication management. And so, for example, she's on Coumadin to prevent future stroke. We did what's called an INR. The INR was below the therapeutic range. And I said, well, she just changed over from assisted living into long-term care. It's been fine for 3, 4, 5 years where she's been living. So instead of changing the dose of the Coumadin, I said, okay, let's just repeat it in 4 or 5 days and see where we are. What's in that time in the normal range. So, from my point of view as a medical director, say, okay, this is a transition in care between different levels of care that the resident was receiving. What's wrong? Something went wrong. And is this going to affect other people coming in from assisted living or other facilities into long-term care? So there's something for me as a medical director, that's what I would be thinking about. Why did this happen? Kind of doing what's called a root cause analysis. Did she miss a couple of doses of Coumadin the day or day before she came over to long-term care? So I'm still going forward. Okay, resident decision making is very important. Ensuring that there are policies and procedures with respect to that. And again, medical director may not be involved or not involved, but these are areas that it says we're to be seen providing guidance and oversight as to resident care and policies and procedures. So this is some of them. How many of your medical directors are reading what policies and procedures you may be having of this? And I don't think they need to look at every policy and procedure, but certainly they need to be open and you need to approach them when you feel that you need help. We talked about a little bit about scope of practice as we get into the latter parts. I'm not going to read all these sentences here. Coordination of care, making sure we have attending physicians. Part of this may be whether you have a closed unit, nursing home, where you have 3 or 4 physicians that have agreed to take care of the patients in your facility, versus having Joe Blow, John Blow, Lori Blow taking care of one patient in your facility. So you've got 20 doctors taking care of 20 patients in your facility. It's probably not going to work. Are signing orders in the assisted living? Again, the COVID-19's gotten us a little bit behind, but I went and wrote it this morning and looked at the orders, the monthly orders for the assisted living. I noticed there's like 2 or 3 folders there with doctors that don't come into the facility. Now, I'm not medical director of the assisted living, but they do turn to me for expertise in medicine and geriatrics and hospice, and I'll help them out. The stipend I get is just respect to the long-term care nursing home skill. But again, there's another problem there. Again, as a physician administrator, again, I can't take care of these all at the same time, but it's kind of back here, right burner. Maybe there's some issues that need to be addressed. So coverage is important. How often do I get calls saying, well, this doctor is on call for this attending physician on the skilled unit says he doesn't know the patient, he's not going to give any orders. Okay. The doctor is not available, on holiday, they're off call for the practice. That happens. It's your medical director backup. As you may be aware of already, one of the main goals for long-term care is for having residents attain and maintain the highest practicable level of functioning, physical, mental, and psychosocial well-being. That's in the surveyor guidance. Do you review practitioner credentials? What are the minimum? Maybe minimum, there may be other stuff. again, the main basics are probably the surveyors will come in, they'll ask, I want to see Dr. Winn's license, make sure that's up to date. I want to see Dr. Winn's medical insurance, liability insurance for clinical care. That's really the basics. And how do you contact Dr. Winn? What's his license number and all that stuff? But you can go beyond that as well. And again, these are areas where, in theory, or oh, sorry, yes, that's excuse me, facilitate feedback to practitioners. It's very hard for physicians to give feedback to physicians. Because physicians are very, I guess in a sense, egocentric, and any kind of suggestion, they take it as affront to their abilities. But it's something that we have to do. It's the same thing with working with families, having those difficult conversations. Often dread going in, but I make sure I'm prepared, and usually it works out pretty well. I feel really good after having those communications. But it's tough. It's tough. Review consultants' recommendations. I always tell this morning we're talking to these other resident physicians that were with me. They're in training, and so we do have a geriatric pharmacist faculty with us, and he brings in his fellows, and they were talking about recommendations that the pharmacist may have. So there's actually, for me, there's two sets. There's the consultant pharmacist by regulation needs to review all the medication of all the residents in the facility once a month and provide feedback to the facility. And then there's also these I guess, students, and they're not in practice yet as far as the pharmacy goes. But they were kind of saying, well, we have this and that. And so my resident physicians that were with me were saying, oh, okay. And I said, well, hang on here. So, you know the patient the best, the physician. You have to take their recommendations into consideration. It doesn't mean you follow necessarily what the recommendations are. It's the same with the consultant pharmacist. There may be reasons why a patient's on a certain medication that the pharmacist is not aware of. So we have kind of a more all-encompassing perception of the patient condition and what the history is. So I alluded to this before, as you can see here. Whoops, there we go. Right. So these are the 9 functions of the medical director, physician administrator, that the Society for Post-Acute Long-Term Care Medicine. Underneath these, there's various tasks. This document expanded is about 7 pages long. This is what's called high level or low level intensity services. So we really alluded to this in many ways, okay? Employee health may be part of medical director obligations and expectations, but usually that's separate now, but it may depend on where you are. Where I was medical director 25 years ago, I would do a quick kind of employee health. Basically, it was orientation. It was, hi, how are you? What are you doing? Where have you come from? Let's talk about immunizations. My expectation is you're going to get a flu shot each year, paid by the facility. Let me show you, give you some information on how to not bend forward, but pick up stuff, how to transfer patients, that type of thing. So it's more kind of preventive talk. Being involved in community, of course, if your facility is not involved in some ways with the community, again, that may be the lay community or it could be the professional community. As alluded to Jessica there, we have 2 hospital systems that are preferred providers to those systems. The in-person directed care. I'm a little bit ahead of time, and that's fine. I was going to give a 10-minute break, so if you need a bathroom break, we'll do that, and we'll be back in 10 minutes. I have 1:35, so we're going to restart at 1:45, okay?
This conference will now be recorded.
13.
So it's fine, I'll Zoom and everything. Okay, we're going to go ahead and start. I'm going to go on to infectious prevention, control, and post-acute long-term care. And again, I'm just giving you brush strokes. I mean, you could talk about this for 6 hours. Let's see. Thank you. Okay, this is an overview of infections and post-acute long-term care. As I was talking earlier, just a few minutes ago, CMS did shut down all the annual surveys when COVID broke out. I think it was probably in March or certainly early April that they had the survey agencies stop doing all annual surveys and go in and do a focused infection control and prevention survey in facilities, which could result in citations. So it's very important area. But there's a lot of hospital admissions each year from post-acute long-term care related to infections. A lot of them may be pneumonia, influenza, COVID-19. Very costly. There's anywhere between 2 to 4 infections per year per resident in the long-term care. Urinary tract infections are very common, respiratory, skin, and soft tissue as well. And I added this in as of 2020, this year, up to 25%, and in some states up to 50% of COVID-19 deaths have occurred in residents who are residing in long-term care, assisted livings, and nursing facilities. Very immune compromised. So there's the American Healthcare Association, the Provider Journal. There's fighting through the COVID-19 pandemic. There's an issue, it looks like May 2020. So you can see that if you're getting this journal, certainly as administrators, you're probably going to get them free. And if you're a member of the American Healthcare Association, which is, as I said, the for-profit long-term care organization, you would get this. I started getting it 25 years ago, and I've never had to pay for it.
How do you call it that?
It's called the Provider Magazine, American Healthcare Association. ACHA. So you might want to be aware of that. It's kind of your administrator journal. Okay, infection control. You need to have an infection control program in your facility. And again, the surveyors are going to be looking at whether there's a safe, comfortable environment for the residents that you're taking care of. And the big thing about infection control is to try to prevent infection. One, prevent infection occurring. Number two, if there is an infection, preventing it spreading in your facility. So if there's diarrhea, preventing it from spreading. If there's TB, preventing it from spreading. If there's COVID-19, preventing it from spreading. There's flu, there's C. difficile, preventing it from spreading in your facility. So you may have an infection control committee. That's up to you. In fact, there's only one committee that's required under CMS. Does anyone know what that is? Yeah, I heard some QA, Quality Assessment and Assurance. I think they, in the State Operations Manual, they have it as QAA. That's the only committee that you are required by law or by regulation that you need to have. If you have pressure ulcer committee, falls committee, that's up to you. Okay? Just one thing, be careful about, if you go beyond kind of what the minimum would be with respect to an area of care in the facility, you go beyond that, you are going to be judged by the surveyors according to what you go beyond. So if you have a corporate QA, and you're saying you're going to do all this and all that, but it's more than quote unquote what's required by survey regulation, they're going to judge you by what you have as your policy and procedures with respect to that. But infection control program, you need to have that facility. And as it says here, it investigates, controls, and prevents. I alluded to that already. And so are you maintaining a record of the infections that are occurring in your facility? The soft skin or soft tissue? Are they pneumonia? Are they UTIs? Are they eye conjunctivitis, eye infections? Are there dental infections? Are there wound infections? These are where you kind of gear down. We're looking at a lot more data. Again, it's all part of the whole system of care that we need to improve the outcomes, prevent hospitalizations and transfers, and address costs. Infections are very expensive to take care of, especially pressure ulcers and things like that. So, maintain a record of incidents and corrective actions. There are certain incidents that may occur in your facility that have to be reported to the Department of Health. So if someone walks out of the front door and you have to go find them, you have to report that to the Department of Health, either verbally or written wise. Okay, probably verbally to start, and then you still need to do the incident and figure out why is that occurring. One, for that individual, and then maybe as the medical director, facility-wide, are other residents at risk of, leaving the facility as well, and why is that? Also important is what's called isolation there, that number 2. So for example, with the COVID-19, you're going to have to isolate them. So we had a lady that goes to hemodialysis 3 times a week. So we had to take her from the long-term care 2-person per room to a skilled room. Not that she's unskilled, but that's 1 bed per room. So she's there now. When it comes back, goes out, comes back, and she's kept in her room. One, she's possibly exposed to COVID-19 at the hemodialysis unit and could bring that into the facility. She's screened negative, but again, that's things you have to do. And so certain types of infection, if there's 2 people that have the flu, you could probably put them what's called cohort and put them in the same room, assuming that there's no other complicating factors that might put them at increased risk. So one of the challenges is resident rights and well-being, try to prevent the control and spread of the infection. So for example, if you have 2 people with C. diff, you could probably put them in the same room. And there may be exceptions to that. So you have to look at each one. But instead of having them stay in a room where the other resident doesn't have C. diff, you got to get them out of the room. Either move the one that doesn't have it to another room, or the one that has it to another room where there's another C. diff patient. Center for Disease Control, it used to be called, it's still called the CDC, but they did change their title. It is the Center for Disease Control and Prevention. It's just not controlling. You want to prevent these infections. So, and again, when the surveyors come in, they may say, tell us about your infection control program. One, they're going to speak to you, they're going to interview you, they're going to observe you, providing personal care where they're using the personal prevention equipment, PPE, okay? They're going to ask about that. Yep. This time of year, September, you need to be thinking about immunization program, getting all your residents immunized against the flu and all the staff. For some reason, a lot of people are apprehensive about getting immunizations. What's going to happen with COVID-19 when we eventually get a vaccine. And it looks like if you're going to get a vaccine for COVID, whichever one it is, it looks like you're going to need 2 shots. And the second shot 3 or 4 weeks after the first. That remains to be determined. So are we going to be telling our staff they need to get immunizations against COVID-19 to be able to work in the facilities or not? I don't know where CDC and CMS is going to come on this, whether they're going to say it's required or not. And people may require, a doctor's note to say that they, for a medical reason or I guess religious reason, they would not want to get that shot. But you need to be thinking about that. So every year I have a drawing, and every staff member, they need to get the flu shot at the facility, provided at no cost by the facility, or they've gotten a flu shot at the doctor's office. They bring in and we put them on a list, and then we kind of give them a little ticket that we put in, and we have the drawing. Okay, and I always usually spend $400 or $500 of my money doing drawings. So I have drawings for like, I give cash $50, and then like 4 for 50 and 1 for $100. I do that to encourage, because we want to get to a certain percent. You may be talking about, you want to get that herd immunity. You probably heard that term, herd immunity. Well, you do need to be effective for flu vaccination. You need to get 60 to 70% people immunized to get that herd immunity from the flu. And that's what you want to aim for in your facility, 60 to 70%. That's all staff. Okay. So that's something that's going to be, looking at your immunization program. Other areas would be tuberculosis screening. Excuse me. And there's, again, I'm just giving broad strokes. There's what's called the 1-step and the 2-step. Anyone tell me in this room anyways about what the difference is between a 1 and a 2-step?
2-step, you give one, then a little bit later you give a second.
Right. So the 2-step is that someone may have kind of a slow immune system. So you give them the first TB skin test and their immune system's not revved up. So it comes back negative. But if you give the second one, say at least 7 or 10 days later, and it's positive, that's a true positive. It's negative the second time, that's a true negative. So someone could actually be positive, but be basically a false negative test the first time it's given. So the first time a new patient or resident comes in, it's going to be a 2-step. Then annually after that, it's a 1-step. Okay. So again, as administrators, as DONs, you're going to need to know this. Okay? And you need to also know how to measure a TB skin test. It's not redness, it's induration, which is when you kind of go over and you feel, oh, there's a little bump there, and then it goes away, and that's it. Okay. And not to be critical, we learn from each other, but I remember once, a site where I do consults, they say, oh, the nurse called me up, or whoever called me up, they not being a nurse, they said, oh, they got a positive TB skin test, oh my God, and they're in the hospital, oh my God. I said, okay, let me go and see. They said, well, it's like 2 centimeters, 3 centimeters. I said, holy macaroni. So I got up there, and well, it wasn't 2 or 3 centimeters, it was 2 to 3 millimeters. Okay. So you need to, and again, so we taught that person, hey, it's induration, it's not erythema. Okay. Pest control, this time of year when it starts to get colder, you're going to see the mice coming into your facilities. They somehow get in there. Surveillance obviously is very important. And one of the big things about infection control is the appropriate use of antibiotics. So that last one, it's called antibiotic stewardship. So CDC and CMS are very involved with ensuring that we as facilities are looking at antibiotic stewardship. And again, this stuff has been going on in hospitals for years and years and years. It's just kind of really trickled down over into long-term care, because we are taking care of a very fragile population usually. Hand hygiene. Okay. Wash hands prior to seeing patients and after seeing patients and procedures as well. And again, these are self-explanatory, but the surveyors, you know, they're kind of the dog, the tail that wags the dog, but we need to get away from that. They will be looking at that when they come into your facility, infection control. I look at this stuff because when I'm preparing to present stuff, not necessarily this course, but other courses, wash your hands prior to and after, even if you wear gloves. After you take your gloves off, you're supposed to wash your hands. And you're supposed to change your gloves and everything and wash your hands if you're going from one site of infection of the body to another. So I do remember an instance where we had the physical therapist was doing wound care, and she had her gloves on and everything, and she had long hair. The surveyor was there watching her do this wound care, and she kind of went like this and pushed her hair back.
Oh, no.
Yeah, so again, it happens. It's kind of you know, it's just like they're saying, well, with COVID-19, you just keep your fingers away from your nose and keep your fingers away from your eyes and your mouth. And that's something we often do, right? It's just kind of whole new behavior. Okay, factors associated with spread of infection. Obviously, there's institutional, which are kind of the internal stuff, the structure in your facility, the environmental structure, and then obviously the resident. What medical problems do they have that will put them at increased risk? Okay, so institutional factors, you can read these. The common air circulation, shared communal space. So what's happening now? You know, initially, patients with COVID-19 you're in your room 3-4 months, starting in March through June and part of July. And only now are we coming out into the dining room, the communal area to eat their meals. But there's one per table, and the tables are 6 to 10 feet apart. And you're doing shifts rather than everyone coming in the dining room to be able to do the social isolation. You're doing it in shifts. So you get 1/3 of the residents in for a certain time, the other third get those out. So again, things that we're doing with COVID-19. Transfer residents to and from the hospital. So, you know, the facility where I am, initially they said, we're not accepting any patients from the hospital. We don't want COVID-19 coming into our facility. The hospitals weren't very happy about that. There was the case in New York State where the hospital system or whatever, they were saying, we're going to ship these patients whether they have COVID-19 or not into your facilities. You're just going to have to take care of them. Didn't work. That's why you end up getting these COVID-19 wings. Where I am, they put a whole wing of, which would have, I guess, almost 16 patients on that wing. It was all put up, ready for COVID-19. We'd seal the doors at the end, all the PPE in the halls. And there wasn't the big surge that we had expected, but we were ready. And now they've moved the special doors down more towards the end where we have 4 rooms. So that's something to look at. Contact with healthcare workers, visitors, and other residents. Still don't allow resident family members come in to the facility. We can have the resident go outside to meet their family members, but again, it's social distancing, it's wearing gloves, it's wearing masks for the resident and the family. And again, various facilities may be in various degrees of kind of quote unquote opening up. Food handling, again, this is important. Just remember, if there's diarrhea in your facility, it may not be C. diff, it could be something in the food. Salmonella, Shigella. And sometimes you may need to have the Department of Health help you. Resident factors, who we take care of in long-term care, they're all immunocompromised. I'm immunocompromised. I don't have diabetes, but I'm over 65. My immune system's probably not as good as a younger person. I have high blood pressure. That's under control. So again, compromised health, but certainly diabetes, individuals with cancer that may be in your facility or immunocompromised. Physiologic reserve is something we look at, is that someone may not have a problem, but if you stress the system, so for example, someone that has coronary artery disease may not have any symptoms, but they end up in the hospital for surgery and you give them a whole bunch of IV fluids during and after surgery. And all of a sudden they go into heart failure. But the reserve that they have is not there. And in geriatrics and older patients, they may have 50% normal function of their heart, 75% normal function of their kidneys, 30% say normal function of their brain. And all this is like a kaleidoscope where all these, when people get older, they don't become more alike. They are more and more different as far as the different body systems and the reserve, quote unquote, capacity that they have. Common infections, again, as administrators, we need to be looking at these. Urinary tract infections, Foley catheters. One of the quality measures is how many people in your facility have Foley catheters. The nursing home compare, maybe there. Bronchitis, influenza, MRSA, C. diff, COVID-19. Other things, less common. Less common infections, scabies. You need to be thinking about that. People having these itchy rashes just don't go away. Could be shingles. Actually, I've diagnosed shingles several times over the phone, where you got that, the dermatome, kind of a certain area. And the nurses were very good at saying what the rash looks like. Be asking more questions. MRSA, VRE, when you do your QAPI, looking at infection control as part of your QAPI, your QA, we ask how many residents have MRSA, how many have VRE. Norovirus, you don't want to get norovirus. That's the cruise virus. I mean, it's devastating. It's a diarrhea illness. Everyone's going to get it. And you take care of that in your facility without sending them to the hospital, because the hospital doesn't want them, and you've got 50 residents in your facility. You need to start taking care of them where they are. And again, there's COVID-19. Transmission precautions. The airborne, COVID-19, mask, N95. Contact precautions, again, probably related possibly to COVID-19, although we think that the virus may be inactive on surfaces after 24, 48 hours, but still, I guess there's a chance there. So we wiped down. So Z came in and said, hey, I wiped down the podium, I wiped down the computer over there, I wiped down this microphone, which doesn't work. Should have got him to wipe down that. All right. Universal precautions is basically any body fluids or waste are potentially infectious. In other words, they may contain blood. So someone like HIV, I don't know, maybe you're going to be administrator of an HIV nursing home. That'd be different. One of the big dilemmas we have is deciding whether someone actually has an infection or actually what's called a colonization. In other words, the bugs are there, but they're not causing an infection. And urinary tract infections are probably overdiagnosed, overtreated with antibiotics. We want to prevent antibiotic resistance from occurring, because that's really bad. If we keep throwing antibiotics at people that don't have infections, they're going to acquire resistance to that antibiotic that we can't use in the future. So we may have what's called asymptomatic colonization. I get challenged. I have one patient I take care of. She's at home, and the urologist has ordered UA with CNS every month. And so the home health is doing these UAs, and so I'm getting these UAs that come back, and they have some pus cells in, which are at very low levels, say like 5 to 10 versus 50 or 100. And they say, well, doctor, when we did antibiotic, and I just said, listen, if the urologist is ordering these tests, you send these test results to the urologist and have him take care of it. Because one, I believe on my inside that that person is probably having a colonization. 5 to 10 white cells in the urine shouldn't be treated. Okay, there may be other things you look for, change in mental status, fever, obviously, things like that. Same with respiratory. Okay, you could get MRSA in the respiratory secretions. Well, is it a colonization, or do they actually have an MRSA pneumonia? Well, you're not going to treat the colonization. Wounds is the same thing. You know, oh, get a wound culture. Well, there's a certain way of getting wound culture. You just don't go in and look at the wound and take a swab, send it out. You're going to have bacteria that are maybe growing on other bacteria. So you're going to get 3, 4 different types of bacteria. There's a special way to do wound culture. And hopefully the wound specialist that's coming into your facility knows that as well. Antibiotic stewardship. Okay, so again, unfortunately, healthcare is a very regulated industry, and part of the infection control program is that you must have an infection preventionist, or maybe a nurse. Usually it would be a nurse or an LPN, could be an RN, an LPN. That's required. Goal to combat emergence of antibiotic resistance. Part of what's called the COP, conditions of participation, for you to be eligible for having residents to come in for which CMS is going to pay your facility for their stiff rehab care. So this may be part of your quality assurance committee, looking at what antibiotics are being used, was it the appropriate antibiotic? Another aspect is, okay, let's go ahead and we'll start antibiotics for maybe this urine infection. We'll start with 3 days, and hopefully the urine results will come back. And then you either continue, or if you order 10 days antibiotics and there's nothing growing in the urine, that you actually call back or be called by the facility, say, hey, there's no infection in the urine, we have 10 days antibiotics. Well, you should stop them, right? Not continue to go the full 10 days. So this is kind of looking down into the weeds, antibiotic stewardship. Again, you can read these to yourself. Duration of treatment. We have an infectious control specialist that comes on our grand rounds at family medicine. And you know, when I went through medical school in my training 30 years ago, graduated 78. We were treating for 7, 10, 14 days, but sometimes only 3 to 5 days is all you need. Although I will say that an older person is probably more, has a more serious urinary tract infection than someone that's 30 or 35 years old if they're female, say. So we don't use, like, not uncommonly, you use sometimes just 1 dose tablet for UTI or 3 days, but that's not going to be adequate for an older patient. So I've come down from 10 to 7, sometimes 5 days. But again, that's where your physician, medical director, again, can get information also to your attending physicians. Okay. So obviously there's a whole team involved with this. Trying to think now, again, pulling from my experience, good or bad. Yeah, make that comment later on. Also, looking at antibiogram. And again, I just want to sensitize you to this. This is where it is. So if your administrator is your DON looking from these 2 hospital systems, what's the antibiotic resistance or sensitivity to different bugs from hospital 1, hospital 2? That may help you decide which would be the most appropriate antibiotic to start. You don't want to wait 5 days or 3 days for a urine result to come back, and then they end up getting septic and going to the hospital. You often have to start treatment right away. Go along and assess. Also, there's various criteria. How is a urinary tract infection defined? How is a pneumonia defined? How is a urinary tract infection defined if they have a Foley catheter? I'm not going to go into that. But your director of nursing should be aware of this. When you look at infection control, and you're looking at the information that's coming forward to the QA, you need to make sure that these diagnoses are correct. You don't want to be treating an asymptomatic bacteria in the urine with antibiotics. So there's various criteria out there that you can actually just Google McGear criteria, okay, or Lowe's criteria, which some of my colleagues are recommending more than the McGear. The McGear was used more for surveillance, okay, kind of the screening versus treatment. But again, the McGear criteria is a good place to start. And there's also what's called the NHSN, that's the National Healthcare Safety Network. That's actually under the CDC. You can just Google these. Okay, and I already alluded to this. Are they really causing symptoms or not? So it's important whenever I ordered a urine examination this morning. The patient, urine looked completely clear to me, but he wanted the urine done, so I wrote it as urine for urinalysis with culture sensitivity if indicated by UA. If you just do UA, or you just get back a CNS, a culture, you don't know whether that's, when we look at cultures, we look at the number of bacteria that are growing in a milliliter of urine. Depending on the level, help you decide whether it's an infection or not, and also give you what type of bug is there. If you got at least, if you're getting 3 bugs in the urine, it's probably contaminated. But you also need to be careful that if the lab says multiple organisms, probable contamination, you need to be careful that sometimes you need to ask them to do the CNS, the culture sensitivity as well. Again, that gets into your infection control prevention. Should be looking into that. Okay, I think we kind of touched on this. You have to have an infection control nurse or professional periodically review your infection control policies, procedures, et cetera, et cetera, et cetera. May need to contact infectious disease physician or your Department of Health. Say, hey, we have an outbreak here. There's nothing worse than a family member calling the Department of Health and saying, hey, do you know that this facility where I have my mom is having a lot of diarrhea or a lot of respiratory problems, which is probably maybe influenza, and the surveyors come in and they say, hey, we heard, okay, you need to be wary of that, what's going on in your facility. And again, there is a shift if the survey agencies, and I've been involved a little bit with them recently, although the COVID-19 has kind of cut down the meetings that we were having. Whereas they're coming back and they will come to a facility and say, rather than just being the tail that wags the dog, okay, you're not doing well on your pressure ulcer evaluation and treatment. We're going to give you a citation, but by the way, here's a resource that we suggest that you go to, either online or here's a pamphlet or whatever, or we're available to help you with some of this. And so that's really a turn of events, but again, with the COVID-19, but that's what they're saying. We're putting a little bit kind of one-page things together. Okay, we've done our survey. This is where you're having trouble. You're going to probably get a citation. But one way of trying to improve yourself is maybe contact this person or contact this website or do this training under CDC, because CDC can have trainings that you can take online. Okay. I'm going to move forward. Is that all right? I'm not in a race, but okay. So standards of practice. All I would say, this is a very short, this is going to take 5 minutes at the most. But this is one of the areas that I was asked to present. And then, as I said, I added copy QAPI, which I think is much more important for a lot of these. So standards of practice, obviously requirement for long-term care facilities. It goes into the state operations manual. Remember, there's various professional organizations such as physicians, non-physician providers, healthcare workers, administrators in long-term care. Okay? You're going to get a license, right? You're going to have standards. This is what you're learning about. This is some of the information, knowledge that you have to have. These are the standards. Okay, so probably driving the people that are looking online, probably driving them crazy when I keep turning around. I'm sorry. So again, it all is related. And again, I added this, is the overarching principles of practice in the facilities is to ensure that we have professional, competent providers, whether they're nurses, nurse aides, rehab, dietitian, kitchen, physicians, to help our residents obtain and maintain the highest practical physical, mental, psychosocial well-being. Care has to be person-centered. We have to respect choice, goals of care, necessary to ensure resident rights, dignity, autonomy, privacy, socialization, independence, and safety. I mean, that's there. That's what it's all about. Everything is underneath that. Everything's underneath that. That's what the surveyors are coming in. Well, we have all these areas that we're going to survey, but it comes down to wound care, falls, you know, it's all related. Actually, this information was given to me by what's called a QIO. Anyone know what that stands for, QIO? Quality Improvement Organization. Okay, where you are practicing, you need to find out who's your QIO that may be able to help you in long-term care. A lot of these issues. Right now, it's in Oklahoma under the CMS contract or scope of work for CMS. It's Telligen, Telligen. Okay, so they're having, they got the contract, I think, for 5 years. They started within the last 9 months. And they actually have Zoom seminars and that type of thing. They talk about COVID, pressure ulcers, falls, all that stuff. So you might want to, and you can get on their email list. Telligen is the QIO for Oklahoma. They also do several other states. But that's money that CMS is giving them to help you do better to provide care. So you can either, it's not compulsory that you be involved, but suggest that you do that. Okay, and it's kind of the practices I alluded to for all professionals. Well, what are, you know, this is actually, this comes with the state operations manual. Well, how do they define the standards of practice? Well, obviously, research, expert consensus, manuals, textbooks, publications, you know, dietary manuals, nursing manuals on how to treat and prevent pressure ulcers. Again, that's what it's kind of a little bit nebulous in the sense they don't specifically tell you which ones, but they say these are the areas that you could actually look at your standards of practice. And then obviously, scope of practice looks at state licensing boards, which folks are going to write your exam, right? You're going to get a license for Oklahoma, and then I think, isn't there a national exam that you folks write at the end? Yeah. So it's applicable, hopefully, if you're going to other states. This may not just remain in Oklahoma. And then obviously various legislative laws that tell you Oklahoma what the requirements are for licensure. Okay, let's see. I'm about 15 minutes ahead. Why don't we go ahead and give you a 5-minute stretch, and then we'll go into the last inning here, okay? 5-minute stretch.
This conference will now be recorded.
They're new to Oklahoma. In Houston.
I have one in the car.
She's doing the case management to buy up some smaller homes. In Oklahoma, 3, 4.
That's what I'm learning all day long. I wonder how good that
I was about to call in the Z Patrol.
Oh, Oh, he
I
heard
got the
you.
word.
He's always here. You can hear everything.
Okay, great. All right, so quality assessment and performance improvement. This is one area that I thought, rather than say one thing about it, that we spend a little bit more time. And this is where I don't want to scare you away from becoming an administrator, but there's going to be, if you're working with the quality assessment and performance improvement with your DON and the other members of your QA team and medical director, you're going to have to know some of this stuff. And it may be a little bit harder if you're not from a healthcare background per se. So kind of bear with me. All right. Okay, again, okay. Provider Magazine, I alluded to, this is one of your journals. Quality on the rebound, very, very important part. You can actually see on that slide, it actually talks about PPE shortages in assisted living, talks about COVID-19 as a barrier to testing and things like that. It's an important area. So I have a disclosure statement. This, some of this information I've gotten from two physicians, the presentations they presented at the national level 3 years ago, for this organization that I kind of quote unquote volunteer for. I don't get paid, volunteer for them, the various things. Dr. Levinson talking about QAPI, and there's a Dr. Nelson Gillespie talking about quality assurance performance improvement for the interdisciplinary team and post-acute long-term care. So quality assurance and assessment, actually should be assessment and assurance. Reverse there. Is the only committee that's required under the Code of Federal Regulations, CFR, Code of Federal Regulations, I already told you that. Does have a core membership. Should be the administrator, the DON, should be a physician, doesn't need to be a medical director, should be a physician. And there are others involved as well. And I'm sorry, I didn't look it up last night before I came this morning, but you can go to the state operations manual, look at the quality assurance assessment, Code of Federal Regulation, and we'll tell you what the membership is. You can have as large as you want. Probably this, what they call the infection control or preventionist, should be obviously involved as well. But you could have a consultant pharmacist be involved because they may have, a lot of the pharmacists these days actually are getting PharmD, Doctor of Pharmacy, rather than a bachelor's of pharmacy. So they know a lot about medications. They have these PharmDs are working side by side with doctors in the hospital system. And as I said, where I am, I have a PharmD faculty member coming in and helping me know a lot about all these medications, which include antibiotics. So one thing about looking at quality is you need data. Okay, so we're going to be talking a little bit about data. Data that doesn't mean anything and data that means something. It's got to be useful. If you're measuring something and you're not using it, then stop measuring it. Okay. I had that question asked several years ago where I was medical director of another facility. So why are we collecting all this data? We're not doing anything with it. At least, you know, like 70% of it. We're doing all this stuff and we're not doing anything. It's not helping us make decisions or changing the care that we're giving. And now this is 20 years ago. But again, collect data and make sure you're using it and make sure it's useful. Obviously be aware of important issues. Okay, so what's the important issue now as far as data goes? COVID-19, right? How many are you having coming into your facility that are COVID-19? How many staff? You should be collecting data on that. You actually have to report all that now. So it's kind of, CMS is kind of the tail that wags the dog here. And looking at not necessarily individuals, but looking at processes, okay? Root cause analysis. Why did this person get a pressure ulcer? Why is this person falling? Why is this person losing weight? Losing weight, give them a supplement. Well, no, that's not going to work. It's going to work as a team. I have a patient who's a peg tube. He's having some intolerance to different formulas. So I'm working with the dietitian on that. I'd say, well, what medical things could be going on? Could he be diabetic, lose weight, that actually, I just saw BMP come back, basic metabolic panel, come back that they ordered. His blood sugar was 317. So maybe he's losing weight because he's spilling all the sugar over in the urine. So maybe we need to control his diabetes better. Also, if he's hyperthyroid, thyroid's overactive, that can make you lose weight. So it's not a question of a dietitian in the kitchen was saying you need to increase the formula and the supplements in between, all that. Well, that wasn't the answer. So you may go down the wrong path. Again, we need to focus on need to accommodate the regulations that we have to abide by. But again, try not to let the tail wag the dog. So pearls for quality assessment and assurance committees. This is kind of straightforward. Obviously, people need to be adequately trained, irrespective of what duties that they're responsible for, whether it's QA or nursing care or physician. They need to know what they're doing. And then must distinguish clinically significant from incidental findings. And I'll show you some information with respect to that. So definitions, guidance to surveyors. This is as far as QAPI. Sorry, CMS, I said QAPI, QAPI. FTAG 880, okay? It actually tells, these FTAG areas, it gives guidance to surveyors. This is what we're expecting. This is how you can evaluate whether these expectations are being met by the facility where you're an administrator. Okay? So it actually says right in the document, quality assessment, quality assurance, quality improvement. The way I look at this, and it's not completely correct, the quality assessment is the past. Okay, okay, things have been done. There's been outcomes. We're going to see if things were bad, if they were good. Okay. Looking at quality. Quality assurance is, well, yeah, let's try to not prevent these bad outcomes from occurring. Then quality improvement is, let's do even better. Okay. So some good examples, actually, just to kind of let you know, this has been going on for probably, let's see, 33 years. There was the Nursing Home Reform Act, 1987. That's where all these regulations and ECTAG started from. They knew then that they were going to be using the Casper reports, looking at these quality indicators, these quality measures as ways of looking at the care that's being provided in long-term care. And that we're going to improve the quality. And if you're doing better, you're going to get paid more. If you're doing worse, you're going to get penalized. They knew that was coming. Do you know the Nursing Home Reform Act of 1987? Do you know what that was based on? That was based on a survey, a report that was Institute of Medicine, which is physician group. They put together reports on nursing home care, and it was abysmal back in the 1980s. And CMS took that report and did the Nursing Home Reform Act. So it's with physicians that actually started this whole thing. There's a Dr. Robert Kane, who's deceased now, but a very famous geriatrician who was involved in that. And that's why I say the minimum data set is just good geriatrics. That's what it is. But anyways, now we move forward to quality improvement. There is expectations that we're going to, just like in the hospital setting, that we're going to improve our assessment and assurance of care, and we're going to improve it, or we're going to get penalized. So, and again, this has been going on in the hospital system. I remember just, maybe 5, maybe as much as 10 years ago, if patients were getting discharged from the hospital for heart failure and pneumonia, and there was another one there, that if they got readmitted back to the hospital was going to get paid less money. It started with that. Now it's all admissions, discharges from the hospital. They get admitted back within a certain period of time from the skilled unit or from getting discharged to the community. They get back to the hospital. The hospital is going to get paid less. It's the same diagnosis, or even other diagnoses now. So I'm expanding it. So this is what we were doing in the past. We're doing quality assessment. And, let me just see how this slide is here. Okay. So quality assurance is traditional, what I alluded to, that's the past. The quality improvement is kind of the future. This is where we are, the expectation of where we're doing this. And then the quality assurance is react. Okay, so there's a bad outcome, what we can do to improve that. And then performance improvement is proactive, looking into the future, making things better in the future. So there's a good example of one of my colleagues gave me several years ago at the national level. You know, pilots and aircraft. If you're 99.9% correct on your quality measures, as far as getting that plane ready to fly, and you're at 99.9%, worldwide, that's the best you can attain. There'd be like at least 100 plane crashes a day. That's pretty scary. So go. So maintain documentation is very important. As you know, if it's not documented, it didn't happen. In fact, very interesting thing happened to me today. I got this fax from a physician who had taken care of the patient that I actually saw before I left the facility to come here. And there was a note from November 2019. So if that chart had gotten audited and there was no note in that patient's chart, and he had already billed Medicare, gotten payment, that would be denied. Wasn't in the chart, he didn't do it. So I made sure I got put it in the right place, but I said, oh gosh, maybe something happened because, you know, it's a year later, this note shows up as a fax to be put in the chart. It says, please put it into the chart. So I suspect that that physician got audited. They denied. So again, it's ongoing. This kind of, again, quality assurance, identifying when there's a problem, kind of reporting it internally. Some of it's going to get reported externally. Investigation and now prevention. So timeline. We're already in 2020, going into 2021. So this has been around 4 or 5 years almost. But CMS is saying you've got to do better in quality assessment, performance improvement. Okay. So the second bullet there, each annual recertification survey, they may come in and are obligated apparently to ask, tell us about your quality assurance and performance improvement. Okay. They're required to ask that. Show us documentation that you're actually doing what you're saying you're doing. Now, part of this is there's a little bit of a gray zone here. The question is, how much of that information are you obliged to provide? Because quality assurance is internal, okay? It's confidential. So this is in confidential information. Do the surveyors really have access to the nitty gritty of what you're doing? They look at the broad strokes. So that is kind of a area that's going to be more clarified, perhaps. So, for example, you may not be doing as well as you helped on preventing or treating pressure ulcers or preventing falls. And the surveyors have come, they've done everything, you know, they've not had any concern about falls or pressure ulcers, and then they ask you to look, you know, at what you've been looking at. And you say, well, we've been concerned about pressure ulcers and falls. They can't go back and say, oh, we're going to look at that more and see if we need to give you a citation. You're not supposed to be able to do that. So that's something you need to be aware of. Are you familiar with the term IDR? Informal dispute resolution. Okay, that's where you can challenge a citation. And actually, it may be time consuming, but if you think that you're in the right, you should challenge it. I do remember, I guess it was 1.5 years, 2 years ago, we had a bad, an unfortunate outcome on a patient, and bad outcomes happen. You can't prevent them all. The surveyor came in with a complaint. He said, we've reviewed everything. You did everything right. You did everything right. But this was a bad outcome. We're going to give you a deficiency. And I said, I was there. I said, you can't do that. You're saying we did everything right. And there happened to be a bad outcome. If you're doing everything right and it's a bad outcome, that was an unavoidable outcome. It wasn't avoidable. And so we actually get all our documents together. And then after we were ready to submit it, they came back and said, yeah, you're right. We're not going to give you a citation for this. It wasn't it wasn't substandard care. You did everything right as far as this, and that. So we, again, will not give you citation. Of course, remember the surveyors, they are in contact with the feds, the CMS. They'll say, hey, we've got this citation we're going to give. What do you think? And again, the level of deficiency may, as you know, there's different levels. Did they talk about levels of deficiencies yet? They did. Okay. So you know about that. So just kind of be aware of that. So that ended up going by the wayside. I actually have gone once where I was a medical director before to IDR, and we were getting a citation for weight loss. And there were 3 patients that were giving us examples. And I actually explained this to an online course I gave 2 weeks ago on the national level. One of them was a lady that was really obese, and she specifically wanted to lose weight. Okay, so that was weight that was intended, right? The other one was a patient with heart failure who we put on a diuretic that lost 20 pounds of water, and they were saying she lost 20 pounds in these 2, months apart or whatever. We said, well, yeah, she lost water weight, not, tissue weight. So we got rid of so that was number 2. I don't remember the third one that got absolved. They couldn't. You can't do it, man. He said, what's going on? So I had to write a report and everything. So again, that medical director may be involved in those at some point. Okay. Again, if you go to CMS or just do copy QAPI, that's going to take you to a CMS website. This was kind of the training that went into effect. This is the 5 steps. And again, it's there. Hopefully somebody is going to speak to you about that. You should be beyond what I'm going to show you. So training is mandatory. This is back in 2017. The facilities where you are should have gone through this training, should be know more how to do better quality assurance and performance improvement. Okay, it's mandatory. If you can't measure it, you can't improve it. Well, we're doing a really good job healing pressure ulcers, but a really bad job preventing them. Okay, show me the data. How many pressure ulcers or how many residents with pressure ulcers? Okay, skilled unit patients, long-term care unit patients, hallway 200, hallway 300. Is there a difference? Okay. Sorry, you got to look at that. Disclosure. Hang on. Skip. I don't know why secretary is there. It says a state or the secretary may not require disclosure. The state or the probably should say survey. I picked this up last night. It should say survey. I alluded to that already about how confidential the information is with respect to quality assurance performance improvement. Should not be a basis for sanctions. Already referred to. Oh, we didn't know that. You did a performance improvement project or PIP. PIPs. They want you to do PIPs. They're going to ask you, what PIP have you worked on? And you're saying, well, we worked on pressure ulcers. Oh, wow. Really? Let's go back and look at this again. You're not supposed to be able to do that. You're going to have to, if they do, then you're going to have to really complain. Okay. So this is really the basics already. Again, your leaders should be involved in this design and scope. Obviously, we're way beyond that. Looking at data, you need data. You need PIPs, okay, performance improvement projects. If you're not doing these, you need to start with one and go slow, not start with 5 or 6 different ones. And not say, oh, there's a trouble with weight loss. You that works in the kitchen will find these meals and stuff. This is your job. To improve our quality measure and weight loss. It's supposed to be multiple disciplines. I already alluded to, everyone else was talking about this person that's losing weight. Probably because their blood sugar's out of control and they're hyperthyroid. Those are what the problem is. So they were doing all this stuff for 3 or 4 weeks, and they brought it to my attention, a QA, that these are the ones that are losing weight. And I'm just saying, well, yeah. Yeah. Need to change this somehow. You know, the colors don't show up well. They show up on your sheets very well. They do. They show up better. The high risk and the high volume. Do they show up?
Yeah.
Yeah. Okay. All right. Okay. So high risk. Okay. What do facilities get sued for? They get sued for personal injuries, falls, hip fractures, wounds. Okay. Stage 3, stage 4. High volume. Okay. And again, you know, when you're looking at data, and again, don't glaze your eyes, don't start glazing over now, they may. Looking at incidence, prevalence, impact, what are the health outcomes? And again, these ones on the right-hand side, these are what we're looking for. We want good healthcare outcomes. We want residents to be safe. We want them to be able to make decisions for themselves, or the surrogate decision to help make decisions. Saw an individual today has cancer, and and again, any information you will not probably know this person, but if you do, it stays in this room. You don't discuss it amongst yourselves. Was diagnosed with cancer about 2 years ago, moved into long-term care, said, well, I was diagnosed with cancer, my treatments are finished, I was told I probably have less than 6 months to live. Well, it's 2 years after. He's not doing well. But he actually is very cognitively intact, and we've talked about hospice before. That's where we are. That's what I told him today. So he had to speak to his sister. And we want him to make his choices. So we'll see. So I'm having hospice to come and interview him, discuss the hospice benefit and all that stuff. So, let's see. All right, there it is. I'm sorry I didn't bring it on the bottom there. This slide, again, I took it from another presentation from those other two. So this one I was just kind of talking about. Okay. So PIPs must conduct sustained performance improvement projects. They're going to come in. And I do remember years and years ago, surveyors came to me when I was in the building and they said, tell us about your QA committee. And I'm talking 25 years ago. I said, there isn't. They said, what do you mean? I said, we're not meeting. Obviously, that's all changed. They're going to come and ask, tell us about your QA committee. As I said, you got to start slow. Start with the hanging fruit where you think you can make changes. So, are you, as administrators in training, when you go into your first facilities, are you ready for you and your facility to QA PI? So, gets into some of these fancy terms, RCA, root cause analysis. So, looking at the outcomes that we're getting. Why is that? So I'm going to show you some of the tools that your WAPI may be considering to help do what you should be doing. The other thing to remember is that you folks are, some of you involved in quality assurance already in some of the facilities. Okay. So how often do you meet?
We meet depending upon what our performance improvement plan is, weekly, monthly, or quarterly.
Okay.
A lot of our PIP teams meet weekly.
Yeah. Okay. So that's a good point. So meeting every 3 months, it's not going to do it. Okay. At least the whole committee, at least every month. But not the QA committee itself doesn't need to be doing all the PIPs and reporting necessarily, doing all the work themselves. They have the subcommittees or subcommittees like doing a PIP meeting every week, and then at the monthly meeting or the quarterly meeting, they bring that information forward to you. Okay, so ideally, you know, your quality QA committee may be meeting monthly or quarterly, and it may only take an hour or an hour and a half to go over everything, but a lot of the information needs to be gathered outside the committee by your PIP team that's working on the PIP. So that's good. So, okay, let me just go forward here. So here it should actually say root cause analysis, design a quality plan, performance improvement project. And this is kind of element 4 of that house pyramid that you saw. Identify the problem, put a PIP team together, not just a dietitian or the person working in the kitchen for weight loss. Not going to do it. Okay, because you need different perspectives. We all have expertise in different areas. So again, in the middle there, it says answer or ask the 3 questions. Okay, what is the problem? What are we trying to achieve? How will we know when we've done better? And at the bottom there, it talks about the PDSA, Plan, Do, Steady, Act. Okay. So, okay. This is the Plan, Do, Steady, Act, or Plan, Do, Check, Act. You can see that you start at the 9 o'clock one. It says identify your output, what your expectations are, what process are you going to put in place, how are you going to measure numbers, I guess, in some way. What are you hoping to achieve? And you're kind of going through, kind of go around and okay, we decrease our pressure ulcers from 20 a month to 10 a month. We want to do better. We want to get it down to 5. So you kind of go over again. Now, sometimes when you make changes, things may get worse. But you can see on the outside of that circle is various instruments or tools that you can use, like brainstorm. Looking at flowcharts. In other words, we do this decision, yes, no. We do the next decision, yes, no. That's kind of flowcharting. You look at things called, I'm just trying to pick some, they talk about histograms and trend sheets and run charts, the Pareto diagram. Anyone here heard of Pareto or used Pareto? Yeah. Well, one of the QIOs here in Oklahoma was saying, well, we're going to go to nursing homes and teach all the nursing homes when they're due their QA how to use a Pareto. Pareto actually sounds simple, but it's kind of complicated. When we teach this course years ago, we were talking about the Pareto. People, even physicians couldn't get it straight, so we just dropped it. And I told them here, I said, you're not going to be able to do it. Anyways, okay. So anyways, you can look up Plan, Do, Check, Act, or PDSA. That may help you. So we're talking about data insanity, looking at inputs and what's going in, what's going out. You know, what are you putting in to make this care for this resident, and what's the outcome? Remembering that you can have what's called feedback. Again, we're looking at structure, processes, you know, feedback to make things worse or better. So I put here on my to the side here as we were reviewing this last night, ABC. Anyone familiar with the ABCs of behavior? The ABCs of behavior is B is the behavior that a resident may have in your facility. A is what is the antecedent? What's possibly leading up to that behavior having emerged? Okay. And C is the consequence. What's the consequence of that behavior? The ABC. So you could say that, well, someone's acting out and yelling and screaming. That's kind of leading to, that's the behaviors, but what's the consequence is they get attention. So actually the consequence, the C, is the desired response that that person's wanting to get from the staff. Okay, so it's the consequence of the behavior that results in them getting the attention they want. So it's the consequence as a feedback that actually is leading to the behavior. So when they don't get that consequence, don't get the attention, that's when they have the behavior emerge. So think of it, it's kind of the same thing with inputs and outputs. incidence, prevalence, we're going to talk about that. I'm going to show you a little bit some line graphs or run charts. I'm going to show you some flow diagrams, talk about fishbone, okay? And then, of course, there's the PDSA cycle that you may use to do your PIP. These are tools. Think of it as a tool chest. At the national level, we use a mechanic tool chest where you've got all these tools in these drawers. You pull the drawer open and you can take a tool out to help you take care of that car or to help you take care of your quality facility. Okay. Now bear with me. Okay. Now, there should be people in your facility that are aware of some of this. Some of you may be more proficient than others, so we need to teach ourselves about incidence and prevalence. And I'm going to kind of skim through this to a certain degree, because I don't want to inundate you. But when you're looking at data, you need to be looking at things like incidence, prevalence of data. Okay? So when this data is presented to me at the QA committee meeting, I will intervene and ask exactly several questions. One is, what is the average daily census? So our admission coordinator who gets patients admitted to the facility will say at the beginning, our average daily census for the month was 70 or 80 or 50. Okay. So what else would you like to know, perhaps up front? If they say we're 50 to 60 is our census for this month, what would you like to know? Well, eventually I'd like to know, well, how many of those 60 patients, residents, right, are skilled? How many are long-term care? Right? So right then and there, they're giving me information that it may make a difference of what population in the facility I'm looking at. So incidence is the number of new whatevers, number of falls over a period of time. Okay? Or a number of pressure ulcers that occurred during the month of July and August, let's say. Okay. So average daily census or bed days of care, okay? And then so the total number of days you want to look at. For example, if we assume here on the bottom that you have 100 residents in your facility for the month of September, how many days in September? 30. Okay. Therefore, if you have 100 residents, and they're there for 30, all 100 of them were there for 30 days, that's 3,000 patient days of care in your facility. Right? And if it's February, how many days in February? 28 usually. So if there were 100 residents, 28 days, that'd be 2,800. So you can see that the numbers are going to change a little. So if we want to know what is the incidence, the number of pressure ulcers in the over time related to the number of residents in your facility, you need to do what's called the incidence. So let's look at an example here. And again, you can refer back. So here we have a nursing home, has 5 new, we're looking at urinary tract infections in the month of September. The census was 100. So there was 100 times 30, i.e. 3,000 patient days, okay? So resident days of care, 100 times 30, 3,000. Move on. Okay, so incidence is 5 UTIs per 3,000 resident days, right? Okay, so if you divide that, basically on that next line, you're going to get 0.0017 UTIs per resident per day. Well, that doesn't really very easy to handle, right? Well, we have 0.0017. So you multiply that, and that's resident per day. You do it times 1,000 days. So you multiply it by 1,000. Okay, so multiply by 1,000 gets you 1 UTIs per 1,000 resident days in the month of July. Okay, so when you look at these rates, they're actually, this is one way that you can compare one facility to another. Sometimes you can find out what the rates are for kind of a best practice in your state or at the national level, all right? So let's go on to the next one. I'm just giving you some examples, just rest. You can look at these at home. So let's change the numbers a little bit. Let's look at February, 28 days. Let's look at census, where you only have 50 patients in February. Okay, so you go through the same thing, 5 UTIs per 50/28. In other words, 5 UTIs per 1,400 resident days, which comes out of the 0.36. Multiplied times 1,000, 3.6 UTIs. Okay, so same number of UTIs, 5 February, different days, different census. Same number of UTIs, February, 5. Okay, but what's happened? The rate actually gone up double. It's 1.7 per 1,000 first, and then 3.6. That's getting worse. If you say, well, we had 5 UTIs in February and 6 in June and 7 in July, and now we're down to 5, that's garbage. You need to know what your census is. And so you kind of see, you need to look at the data, you need to look at it carefully. So I'm going to look at prevalence. And again, this is a little bit more complicated, so I'm not going to go into this per se. But for example, if you're looking at pressure ulcers, you need to see, you need to be looking at pressure ulcers, looking at that data, however you do it right or wrong. But you also need to look at residents who have pressure ulcers. So if you have 14 pressure ulcers in August, and you have 2 patients that have together 12 of those 14, you need to be concentrating on those 2 patients, right? So 14 sounds really bad, but if 2 patients or 3 patients are responsible for all 14, that's different than having 14 patients, each patient having 1 ulcer. See where I'm getting at? So you need to look at that. Same thing with falls. So when they report pressure ulcers, I'll say, okay, we're talking, there's 2 populations in our building. There's the post-acute care, the skilled care, and there's the long-term care. I need these numbers to look. Whatever numbers you're showing me, you need to split them out. Because I need to know if this is a facility-wide problem or whether it's just long-term care, or whether it's just the skilled. Okay? So how about, antipsychotic use? Antipsychotic use in the hospital is big, right? How many patients are coming in on antipsychotics in your facility? So, we're down to almost none, unless they're schizophrenia or they have depression with psychosis if they're long-term care. And I remember surveys, I cite to surveyors, well, we have this. Yeah, I know we're not supposed to use antipsychotics because increased risk of, sudden death or pneumonia. And this one time the surveyors said, Dr. Winn, we're going to be looking at you. And this is at a national meeting or this local meeting, and we haven't been gotten deficiency for use of antipsychotics in our long-term care population because they're being appropriately used for schizophrenia or depression or psychosis. Well documented. We've done our GDRs, our gradual dose reductions, but I see a problem with antipsychotics. And all these patients are discharged from hospital. They're having a delirium. They get put on these antipsychotics, and they come into the nursing facility, skilled nursing. And so we try to, and again, I can't, as a medical director, I can't force them to do things. I can suggest and make recommendations and give them oversight and guidance. If they don't follow my guidance, that's their problem. Okay? So I say, okay, let's look at these antipsychotics, you know, are they PRN? So our policy procedure, any PRN antipsychotic, we do not write. They're not going to, we don't write an order for PRN antipsychotics, so they come in from the hospital. If they're on routine antipsychotics, yeah, okay, let's look at that. Let's look at the doses. Again, if we want to get rid of antipsychotic use, which CMS wants us to, right? Why don't we somehow, if you can, and again, I'm not sure they do this, find out whether they're on an antipsychotic before they even went into the hospital. Okay, did they go in on an antipsychotic? That's been continued during the hospital, that's continued on discharge. So that's kind of looking deeper into the weeds, okay? Try to figure out how to do better. So you've got to be asking those questions, thinking about those questions. Hopefully, a medical director or whoever his representative is, it could be an attending physician. In theory, I think it could be a nurse practitioner that works with the medical director that's helping you with that. So again, you need to be looking at these things. Again, it gets into prevalence. And I'm going to skip ahead here. Where am I? Because this is a little bit more complicated. But basically, incidence is occurrence of new things. Okay, so in July, we had 5 new pressure ulcers. But going into July, we had 15. So we actually had 5 new and 15 old. Therefore, at the end of the month, we still had perhaps 20 or 16 or 17. Looking at the end of the month, that's prevalence. How many pressure ulcers did we have in July, whether they came from June or whether they're new onset? So that's different, right? And what's called point prevalence as well, just kind of point prevalence is where, okay, we're going to look at these numbers from July 15th versus the end of the month, July 30th. So again, that kind of is a little bit more difficult to grasp. I'm not going to go over these aspects, but that's what these two allude to. Okay. So available nursing home data, Casper reports. And at the bottom there, that stands for Certification and Survey Provider Enhanced Reports. You should be able to get these. Okay? So when I always get and again, I feel like I'm a newbie medical director. I have a new ADON. I have a DON that's worked as an ER nurse. She's fantastic. She knows her clinical stuff really well. Very impressed. She's been there 2 weeks. But she needs to learn a lot, probably. So they didn't have, we were supposed to have QA yesterday. He said, well, I just started the job 3 weeks ago, and the ADON just started a week ago. We're not really prepared to do our QA. I said, well, that's fine. But let me, so I did talk to her, and we'll be talking to her about QA. So I'm going to ask, well, you know, I always like to see the Casper reports, which looks at the quality measures. Right? And I'll show you some examples of that. It looks at pressure ulcers, falls. I want to look at infection control, look at accidents, elopements, things like that. They're going to be important. Antipsychotic medication use, I really drill down on that. Pressure ulcers, I really need to drill down on that. We're talking ulcers or residents with ulcers. Are we talking long-term care, skilled? How many pressure ulcers are 1 or 2? How many are 3 or 4? How many have gotten worse? How many have gotten improved? I'm going to really drill down. These are my expectations of you. You want to do this properly. Your QA, you're going to be asking those questions. So you ask for your Casper reports. And, now, when you do your Casper reports, you can look over a period of time. So say you're doing QA, so we'll do probably this for us, we'll be doing a QA hopefully in October to get things started again. We did it in August, but now with the new staff, it's going to, we skipped September. So we're going to be doing QA. So I want to look not just at the numbers for September, if we're doing the QA October, it's looking at September's numbers. That's not going to give me valid or reliable information. So they can actually go in on the Casper report, put in the dates for July 1 to or August 1 to August 30th, and bring up the data for that. But that's not going to help me. Okay, I always say go back 6 months. Okay, So go back, say, for example, from February 1 to July 31 or August. And that gives me more data to look at. Remember, the quality measures that are looked at on the CASPER reports are related to what? Where did they get that data from? Speak up.
The MDS.
Yeah, the MDS, and and that gets all put together. So they're looking at the MDS, which gives the quality measures. But you look at the quality measures for 30 days versus 180 days. The 180 days is going to give you more correct information. So you don't want to base decisions on what happened in September that may not be correct assumptions that you've made. You want to look back. So I always say go back 6 months. And initially they were bringing me 30 days. I said, garbage in, garbage out. Okay? And you need to have the correct data, the correct information to make good decisions. Okay? So let me show you a couple of things. This here, and again, I know you can't read this. So the individuals that are online, I guess if they sent you the PowerPoint, I would think that you might be able to actually print off the PowerPoint as one slide per page. But you can see here, we're talking about pain, severe pain. In fact, if I'm correct, I think they actually took pain off recently. They're not looking at that. I may be stand corrected. But high risk talks about high risk pressure ulcer. And what does high risk mean? L stands for long stay, antipsychotic short stay. So we're looking at anxiolytic medications, antidepressant medications, UTIs, catheters, low risk bladder, valve incontinence, excess weight loss, increased or improvement in ADLs, the basic activities of daily living. And what are the basic activities of daily living?
Toileting.
Yeah, toileting, dressing, feeding. So the way I remember it is, what do you do when you get up in the morning? Transfer out of bed. You ambulate to the bathroom. You toilet yourself. You bathe yourself. You go back to the bedroom. You dress yourself. You go to the kitchen. You feed yourself. Those are the basic activities of daily living. So also the other thing to look at is what's there's so here it takes, so the other thing to look at is, so who's at high risk for pressure ulcer?
Bed down.
Yes, bed bound. Again, they may be transferred out of bed, but you're right. You look at reason why they're at risk. You go through all those different things, but if you have a resident that's low risk for pressure ulcer and the pressure ulcer, and they're not bed bound, you're in trouble. The surveyors will pick up. Okay. Now the other thing here that you'll see is, and again, this is data you can get that they bring to me. This data, and actually, if I'm correct, oh, that's from Oklahoma Foundation for Practical Quality. I don't have my own here. But anyway, you can get this data. So the percents here looks at state average, so you can compare your data to all the facilities in the state where you stand. Actually, it's the national data. So national, for example, as I said, falls, pressure ulcers. What's the national data? It's hard to get as far as incidence and prevalence and all that. Here it looks at, it's called percentile. These are percents. Okay, so this would be. Also remember, as you say, minimum data set is where they get these quality measures from. But where do they get the quality measures from? Is actually from the care planning. And whether it's a quarterly care plan or an annual care plan or a care plan for a change of condition, they will put in the data with respect to these areas. And that's why these numbers can change. The numerator is the number on top. The denominator is the number on the bottom. Care plans were done, and 21 of the 84 care plans triggered for this. The 21 over 84 think is 1/4, right? Why it's 25%. Here there were 104 care plans. You or worst pressure ulcer, 0. You're doing pretty good. But what about this number over here? Here we're talking percent. And here we're talking percentile. So this looks, 80%. You're doing pretty good. What about this one? 96%. What does that mean? Different than percents. And that you will actually get the percentile. One thing to remember is when the surveyors come in, they know this data from your facility. They will say, oh, okay, looks like there's a problem here. We're going to pick out residents that actually can flag. So when you're actually looking at your Casper reports, you can actually have a list of all the patients, and they may be for that 6-month period, and they will show you which ones flagged under these. So you have the residents' names here, and then you have a big long thing for like 19 or 20 possible quality measures, and whether that resident flagged or not. Surveyors have access to that. Okay? So they know, they do their homework before they come into your facility. They know, because the survey process has changed. Well, they're actually doing it all by computer, and they interview the residents and all that stuff, putting all this down. So what about this? Where these stars? Do you think you're doing good or not? Okay. Well, actually, you're not doing good. But when you see 82 and 80, you think, oh, I got 100. That's pretty good. I did an exam. I got 80% on my exam. Well, what this says, with these starred areas, that star, that means, for example, that 82 or 80, that means 82 or 80% of other facilities did better than you. 96% of facilities did better. And you can kind of, if you look at these numbers, you can kind of see, well, state's 14 and state 6, national 16, and you're at 34, 5%. So you're actually, in a sense, okay. So you can use this data to do a PIP. Okay, we have a problem with needing increased help with ADLs, rather than improving. We need to maybe do a PIP on that. Surveyors are going to come in, look at that. Again, tail wags the dog to a certain. And then you other things to look at, you can say, oh, Mrs. Jones, my God, she's flagged in 6 areas, 6 quality measures. Maybe we need to look at residents that have 3, 4, or 5, or 6 flags. And we need to look at those residents, because those residents are going to kind of make you not look good. It's going to affect your star rating, right? All right, so I decided to have this as well, include this. This is not being used anymore because the QIO in Oklahoma changed from Texas Medical Foundation to Intelligent. But this is what we were using up to a year ago. We look at all these quality measures as well, and they would calculate it for you. And green would mean you're doing good, and yellow means you're not doing as well. Red means you got problems. Okay? So again, depending on where you are, this, whether it's Oklahoma or Florida or Kansas, your QIOs, again, your QIOs are there to help you. They will not charge you. The Quality Improvement Organization, Intelligent for Oklahoma, will not charge you for helping you. Okay? So you can contact them. They are contracted to CMS to help you. That's how they get paid. And depending on what their quality measures are, is how many nursing homes they can get engaged in Oklahoma, and how many people are on the Zoom lectures and stuff that they're doing, Zoom conferences. And again, what they were looking at before, and then they would actually combine all these quality measures and give you a number. So it wasn't very good back there. Okay, here we are, 15. And then the goal was to get to 6 or less. You can see that this nursing home actually did quite well. Actually, that's my nursing home. But they're not doing that anymore. The intelligence not using it. But again, depending on where you are, there's different ways of looking at your data. All right. We're doing good. We're doing good. All right, so I'm going to move forward. So looking at data, so for example, some of us are very visual. So some of us may do pretty good looking at tables, like I just showed you some tables, right? A log table in a sense, line table. But other times, maybe looking at graphs over a period of time may give us a better idea of understanding the information. So this is an example, get out of the way so you can see. The people at home have access to this slide. So here we have, I'm not sure. So here we have basically, you can see that there's information looking at falls over a period of time, basically looking over 14 months. But you can see that for each unit, there may have more or less falls, okay? And again, this is your falls per 1,000 resident days. I already told you how to do that, right? Incidence. So it's looking at that incidence over a period of time. So unit A, which is the top one, that could be the skill. Unit B could be your long-term care, or it could be hallway 200, 300, 400. So when you look at your data all together, you may not be able to pick out patterns. You may not have a problem throughout the facility. You may have a problem in one unit or one floor of your facility. And that's where you have to dig down and help your facilities look at this. Because you don't want to interpret wrongly the information that's going to result in you making a wrong quality improvement project and things actually get worse. And then people get discouraged. Again, that's a good example where I say, okay, how many of the pressure ulcers or antipsychotics are skilled patients versus long-term care? And the pressure ulcers, you know, it's divided up. There's 2 patient populations in my facility. Okay. What to monitor, rehospitalizations, emergency room visits, these are reported to CMS. These are available on nursing home compare. Google your nursing home compare and go in, look at your data. The hospital systems that are using your homes are looking at that data. And especially if they're coming back to their facility and they're getting dinged to take care of patients for much less money. Operations, call bell response times. And again, the surveyors will come in. They'll go down to the patient's room, push the button in. 5 minutes, 10 minutes, 15 minutes. They'll come and do that. Okay? Staff turnover, something to look at, as I said. I'm on my 3rd people. Staff turnover, it's a challenge because all of this stuff that my PA or that my QA committee people who are helping to head it are all changed now. I need to teach them. And of course, we're part of the corporate entity, so we need to also satisfy what their needs are for QA. Just remember, their needs are and expectations are higher than what's the minimum that the survey agency will hold you to your higher expectation, okay? And financial, obviously, you know, as administrators, that's where you folks are. You're in finance. You want to get people in, good outcomes, and you want to make money. Even nonprofits have to make money to survive. So whether you're a nonprofit or profit. Okay. Here we're talking about what to monitor, just some, again, I'm just kind of brainstorming, okay, giving you some information. Just think about it. Think, okay, where I am now, and if I'm involved with coffee or will be in the future, what would be, what's relevant, what do I need to know? So wrong code set. Not good. Wrong patient events, wrong diet consistency, wrong medication, elopement. These are never events. And sometimes some of these you need to report verbally on the phone with follow-up of written documentation. So for example, elopement. I think even falls with head injury, you had to send out, I think if you had to Oklahoma, you have to report that to the Department of Health. Survey agency. Okay, the other thing is what we call full disclosure. If there's a bad outcome that occurs, you need to disclose that. So patients given another patient's medication, excuse me. Sorry. You need to disclose that to the person that didn't want to get the medication, the person that got the medication, and you need to form the surrogate decision maker or power of attorney or family member. I've had instances like that were, oh, this is what happened. I said, well, did you report that to the family? They're looking at me. I said, you need to report that to the family. There wasn't a bad outcome. You need to tell the family what's happened. That's going to get you in big trouble if you don't do that. Full disclosure. Uncomfortable situation. Otherwise, Google it. Okay, so let's look at this series of graphs. Looking at over 24 months, we're looking at medication error rate. So here we can see, and this may be January, okay, there's 21 medication errors. And that's something to look at. Well, okay, there are 21 medication errors this month. They'll report this as part of the QA. Well, and then they move on. They say, well, wait, go back. What were they? Tell me what the medication errors were. Because I want to know whether it was serious or minor and what you did. Stop. Numbers don't mean anything to me. Excuse me. All right. So let's go. We'll get a little bit more data. Well, it went up to 31. What did we do here? Did we have a pick? They brought us down here. That's where you have to look at your data month to month over a period of time. So even though we look at numbers in September and August and July, I want to see what the trend is, these numbers as we go along. Sometimes they'll show the trend that after 12 months at the end of the year. So say to myself, that's not good enough. We need to look at it. Last 12 months, in September, last 12 months, October, December. Oh man, we did even better. What's going on? Medication error. What do you think? You think things are getting better? Things getting worse? You think things are just haphazard or what?
Hazard if they're not really doing it.
Yeah, they kind of look haphazard. So this may just be what we call normal variation. So you may say, okay, we got a problem here. Let's do all this, and that. And that would be maybe the wrong thing. If you're looking at data over time, and you'd be able to see, and talk about mean, so average, and whatever. So you add all these up, you could say, well, maybe there's on the average 23 to 25 pressure ulcers through this period of time. So if you start to have an intervention here, whether it really is not a problem, this could just be normal variation over a period of time. Now look at what happened there. It went up to 33, and it went down to 15. Again, the question is there something going on here? Was there a staff turnover or whatever? Well, let's see. Let's just see where I am. Medication error rate. Coin flip. 50 people doing 25 flips. Heads. Coin flip. 30 heads. 6. 15 or 20. 15. Random variation. Common variation. That's why you got to be careful about looking at this kind of information. Okay, so we're talking about common cause variation, which is what you're seeing there. Common cause variation, completely random, flips. 50% chance of heads or tails, right? Okay, special causes. Okay, this is a run chart, perhaps looking at the same information, not necessarily coin flips, but urinary tract infections. You can see on the left-hand side. See there? I don't know if they can see me way up here. This would be the common cause variation. And all of a sudden, it goes up. Consistent. So there's a problem here. It doesn't continue doing this. All of a sudden, it's shooting up. So that's a special cause variation. I kind of printed it in. That's something you need to be looking at. I'd rather be seeing it going the other way, right? I'd rather be seeing this over here and then this down. So if there's a special cause variation for better or for worse, you need to be looking at that. It could be another reason why the urinary tract infections are more common. The question is, are they appropriately diagnosed? Were they colonizations? Okay, were they again, if you're saying a urinary tract infection is defined by them receiving an antibiotic, that's not the way to define a urinary tract infection, that they got an antibiotic. And some people may be doing it. Oh, we got a urine and they got an antibiotic. This was for their urine. They may have, not had a urinary tract infection at all. Other things, we've got 5 minutes left. This is looking at the 5 whys. Okay, so why did something kind of keep going down? Again, this is root cause analysis, looking at the outcome, whether it's good or bad, and why it occurred, especially looking at quality improvement, performance improvement. So, patient was found in the middle of the room on the floor. Well, why were they found in the middle of the room on the floor? As well, they were incontinent of urine and slipped. Well, why were they incontinent of urine? Well, maybe they had a urinary tract infection. They kind of go through why. It's like when my kids, my sons were growing up, was driving me crazy. They'd ask me a question, I give them an answer, they would say why. I give them an answer, kind of more explanation, they would say why. And the thing is, if you go down to the 5th why, usually root cause analysis, you may get to what was the real cause of this person having been found on the floor. Maybe they've been on the floor for, how long were they on the floor for? Well, we didn't find them for 4 or 5 hours. Why is that? Well, there were no nursing checks or nurse aid checks. Well, why is that? Someone called in sick. Well, why is that? Well, they called in sick and we didn't call someone else in. We were overwhelmed. Okay, see what I'm saying? Kind of going in through a whole process. Okay. All right, this is another thing that you may use. I've actually seen this being used in nursing homes. Actually, we use it for physicians as well. So there's a poor outcome, and you can break it down to different areas. Again, it's an area of root cause analysis. And I guess I highlighted it last night as I went through. No, I highlighted it already. Yeah. Okay. So, if there's a bad outcome, pressure ulcers, falls, what about management? What's the environment? What materials, such pressure ulcers do you have? And again, it's not looking at what do we do to improve the outcome. It's why do we have a poor outcome? And in a way you can brainstorm, you have the group together and you say, well, we didn't have enough PPE. That's why COVID-19 became rampant in our nursing home. That's what happened, right? You didn't even realize COVID-19 was there. So processes of care, again, infection control wasn't up to par. We were understaffed. You could kind of figure out, okay, these are the different areas that result in a poor outcome. Therefore, we're going to trying to decide which one we want to concentrate on. Was it the staff turnover that was the problem? Was it the lack of PPE that was the problem with these poor outcomes? And kind of look at that, or try to understand. And then here's another one, looking at urinary tract infections. So looking at, grab rails, that's like equipment, policies and procedures. S-bar is probably the one that you want to look at. Anyone knows that's S-bar? Anyone using an S-bar? Yeah. So it's kind of intuitive. The nurse calls and the doctor's going to say, the nurse is going to report something. Exactly what's going on. So what's the situation? You may want to get more information to that. Okay, so what's going on? Why, is this person admitted to the skilled unit? And most patients, we look at fall rates within like 3 or 5 days within arrival on the skilled unit. Okay, that's one of the corporate quality measures, of our measures that we look at. Why, other subacute rehab patients are at high risk of falling. They come to your facility in the first 3 to 5 days. So we look at that time. And again, you can see nursing, management, education, talk already about the years criteria, to be used by years criteria, to look at high rate of UTI. Okay, so this is not a good outcome. So look, we've got a bad outcome. We want to figure out why that's happening, how we're going to intervene. These are tools that you can help you. It may not be as complicated as this, but fishbone actually is probably used more and more often. And CMS has expectations that they're going to use. Incidence, prevalence, fishbones. Okay, so I am done. This is where you are. Z told me you're kind of the middle third of your course. And hopefully by the time you get to the end of your course, you're going to be taking off this butterfly. All right, so good luck. Be safe. Thanks for having me, folks. Enjoy your day. And I'm willing to take questions. I'm going to talk to the recording, I guess. And for you folks on Zoom or online, thanks for being present.